Thanks so much, Francisco, and it's a pleasure to be here. It's a pleasure to really be amongst all of you are leaders in HIV rehabilitation, and just want to commend you on all the wonderful things you're doing. A couple of comments. It's nice to be back home, actually. My office is just across, about a stone's throw from here. I've been here, part of Wellesley Hospital in St. Mike's for almost 20 years. This is an area that is very dear to my heart. I actually grew up in neuropsychology. My dad was a neuropsychologist, and I think there's lots of work to be done. My main messages today, because I don't have them, so I just want to, after that last piece there, first I'll say that one of them is, and you'll see them in the book, is whatever's good for your heart is good for your brain. And so I'm going to talk about that. And it's really important. It's good for all of us, but in particular it's good for our brains. This is a common condition, or common conditions, and they've been around since I started, and they were before I started. And it's great to get in the recognition for that. And I'll tell you along the way a little bit about context for that, because it's been building a case for a number of years. And there's something we can do about it. So that's really important. The two things I'll say, just in terms of rehab and HIV more generally, and in this area, we have to be thinking about solving this problem. And that's part of what I do at the OHTN. It's part of what I do in my other work nationally. And I think the kind of things that we need to be thinking about is pushing this envelope, to push it to a place where we're thinking about implementation science and program science, thinking about the solutions in the context, the problems in the context of the solutions. And I think that's something that I just want to leave with you, because we could continue to research this, but we need to act on it. So that's one thing. And developing, the argument for cost effectiveness, for costing, and all these things that we've talked, the economics. You can't do research in this world anymore without in that context. This is what we're building. This is what I do for a living. I build things. Hopefully they're meaningful and have impact. But the Center for Brain Health and HIV, and we're still working with this title, because I think healthy aging and something else there is probably what we're going to add to this, because it is part of aging, and it's part of, and brain health to me is about cognition, it's about mental health, but these are the things that we're doing. And so we know a lot about these conditions. I was asked to talk about screening and about rehabilitation, but you can't do that unless you do a little bit of the painting the background, so I'll do that in a moment. The lived experience of HAND, and I'm going to use HAND, not HIV-associated neurocognitive disorders, because I'll probably slur that as I go through anyway, but HAND, and I'll show you in a minute, this has really given us something to put our finger on, and it's helping to identify and really helping us to explain what it is and how we can think about it, how we can address it. And I think the lived experience, Stephanie Nixon, who's here, has done some really nice work, fabulous work actually, with her students. I was asked just to help her along the way with this, but she had students who want to understand more about, physiotherapist students who want to understand more about the lived experience. And they looked, they interviewed 12 women and 10 men. And there's two papers that one's published, one's just about to be published, I think. And one was looking at HAND in the context of aging. And this is really important, because these are actually the first papers that have ever looked at that. So for those of you, most of you in the room who understand the response in the community response to HIV and AIDS, this is not something that's actually permeated into this neurological area yet. I think it's very important. And Robert Reinhardt, who's here, he and I and some others are working on how to build in the education and training and other aspects of the things that we want to do here in terms of promoting this work. And I think for me it isn't about just, as I said, studying the problem but solving it. So I'm going to talk a bit about some of the opportunities for interventions, and as well as models of care in the health system. So just to contextualize this, I have a lot of slides. They're mainly just as backdrops. I think they're going to be sent around. But so you can look at all kinds of studies, hundreds of studies of the prevalence of cognitive impairment in HIV and AIDS. And it varies, but about 30 to 50% of people will have some cognitive impairment at some point in their lives. What I wanted to say is that, when I started in this area here in Toronto about 20 years ago, and I was writing reports telling people that there's a problem here and there's mild impairment, people say, well, it's mild, it's not significant. Mild impairment can be significant. It really can impact a person's life in very, very profound ways. It can shake the sense of self. It can make you think that, there's something in my head. It really is in your head, or it can be in someone's head. And it really is important to identify. So, I'm the only neuropsychologist in Canada that has a systematic clinic that actually does this work. And I fund it. I'm here at St. Michael's Hospital, and I fund it off soft money. So there's lots of work that we need to do in the health system to actually get these services available to people. So one of the main messages here is that mild can be very significant, and it really is important to identify and help people with various aspects of their lives that are important. There's this new nosology. There's the three conditions. Dementia is something that we don't see as much anymore, but there's these two milder conditions, which is principally what I'll be talking about, the mild neurocognitive disorder and asymptomatic neuropsychological impairment. And what they are basically, or how they're different, how they're similar is that there's a mild impairment, at least two ability domains, but the degree to which they impact on a person's day-to-day functioning is different. So in one case, there's evidence of that, and in another case, the patient or the person doesn't recognize it, and the measures don't suggest that there's any problem. And so this is kind of like high blood pressure is a risk factor for heart disease. It's something that's a silent thing. Could be, and so, but we really do think that, and there's lots of debate about this. Some people believe it, some don't. This is where we need to focus our efforts, a lot of our efforts in this. And I should say that it's very likely, it used to be that we lumped everything together. It's very important because dementia, people who develop dementia probably have a different trajectory than those who have these milder conditions. They're not the same thing, it's not a continuum. And I think we know that now. The paper that I've asked to be included is a rehabilitation paper by a group in California that I trained with, Stephen Woods and his group. Did a very nice, some very nice paper around the rehabilitation and a call to action to think about what we need to do. And this is just a decision tree on how you think about the characterization of these different conditions. But I encourage you to take a look at this paper. It's well written, and it really does, it accentuates, I think, more of the academic issues, but it really talks about the kinds of things that are important for us to think about. This is, as I said, HAND. This was done about a month ago or 2 months ago now, just to see in the literature, so this is when the paper came out, how much work is going on in this area. And so there's this explosion of work around HAND, and that's going to continue to go up. So this just shows how important, or how important it is in the academic area, but clearly it's hopefully that will translate into more practical and everyday implications for the people that we're trying to help. This is a complex diagram. It's in the paper, but I just wanted to highlight it. It's a very nice way of thinking about where are the places to intervene, and what are the kinds of things ultimately we want to get to a place where we can prevent these problems in the first place. Right now, we're just reacting to the problem, trying to even figure out how to diagnose, screen and diagnose it when it's a problem. But it'd be nice to get to a place where that works and people that we can identify when there's early signs, so like high blood pressure, and be able to manage it better. Be able to manage it through medications, through behavioral strategies, through lifestyle changes, and so on. So I think that's where we'd like to get to, and that's going to take some time, but I think it's important for us to think about that context. As Simon indicated, this sort of clean and dirty, this is the CIHRRC study in the US, six places. We're modeling this in our work here in Canada on building, and so we're actually using Bob Heaton and Ewa Grant were my mentors. We're building this relationship and doing very similar work so we actually can pool our data and answer more complex questions. But in here, this study that's really helped us understand what's happening in the real world, this is a very complex diagram, but the degree of impairment or probability of impairment is on your left from 0 to 100%. And basically the message here is that as a person's immune functioning goes down, as there are more complications related to medical comorbidities and substance use, as that goes up, there's increased risks of impairment. So this is really a good sort of picture of what's happening in the real world. And it's something that we need to understand much better to think about, what we can do about this, because it really is quite striking that people on the right-hand side are having such high rates of impairment. The point I wanted to make about cardiovascular disease, this is something we've actually lost some ground. We haven't been paying enough attention to this. And the first paper, actually, or first papers, just have emanated in the literature just a couple of years ago. This is something that we should have picked up a while ago, but now we got to catch up and figure out how to deal with this. So cardiovascular risk factors, as you might expect, are going to impact on the brain. They do in everything else outside of HIV. Why wouldn't they in HIV? So these are 4 papers, and not only is it vascular risk factors, but things like obesity and things like metabolic variables and diabetes are going to be really important for us to pay attention to. So those things can be modified. Those things can be, we can intervene. And if we actually address these, we can actually likely reduce the rate of impairment to the brain. So here in Ontario, we have a large cohort study that's following about 5,000 people, and we've instituted sort of an extended screen in a way, of a half an hour assessment of cognition, neurocognitive areas, and about 1,000 people are now being followed over time. This is different from what the clinical practice that I have here at the hospital, where we have about 1,000 people that we've been following for the last 20 years. That's helping us really understand what's going on in terms of, in a broader way. But these are the measures that we use. I'm not going to go into any detail about this, but I wanted to show you what the numbers look like. So again, so here is what I've done is on the left, 42% of people were rated as normal with this battery of tests that we gave. And you can see the prevalence of asymptomatic cognitive impairment, mild neurocognitive disorder, and dementia. And so, these people, this is the real world. So nobody's been screened out here. We're now in the process of going in to figure out what are the major things that are actually contributing to the level of impairment. But what you can see is that asymptomatic group has the largest percentage. And so this is really important because this is the area that's generating a lot of controversy. Now, if you do the numbers in Canada, looking at people living with HIV, I just sort of did some number crunching. You see how many people potentially could have these different conditions. And so, you know, this is something that really kind of blows my mind when I look at how many people aren't being, this isn't being identified, and support being provided to people. So the 1-year follow-up rate is about the same, but it just, again, it sort of contextualizes that it looks like it's about the same or stable, which it probably is to a large degree. But then when we start to look at, you know, who's moving, and this is really important, and things are happening medically, psychosocially, and so about 60% of people had the same condition from time 1 to time 2. There's about 20% improved and 20% worsened, and now we're trying to understand what are the predictors of those things. And just to link this back to what's happening in the US, so we're getting very similar numbers to CIHRRC. So this is, you know, provides some support and confidence that even a smaller battery like we're using, they use a very extensive one, we can get similar numbers so this in the real world. So this is encouraging. This is a study that was published in CROI, and just the point I want to highlight here is just in terms of that stability, but looking at those people who get worse are those who have comorbidities, those who have lower CD4 counts, and those. So these are not rocket findings, but they're things that we need to be thinking about and really identifying and helping people manage the medical stuff that's going on if we want to help the brain. And just to say, this is a study showing that people who have asymptomatic neurocognitive impairment are more at risk for developing this mild condition. So the San Diego group, the CIHRRC, has good data. This is something we should be really paying attention to. Again, people who have high blood pressure are at risk for things that can happen. Very good data to support this. Here's the data from our here in Ontario, and Amy Justice has done some really nice work with this VAX index. It's a sort of medical morbidity index that can be generated from just regular clinical care measures. And just to show you that as you increase the rate of impairment on this index, the rates of neurocognitive impairment go up, which is something that is now so we're now actually collaborating with her and the group in California to actually pool our data to look at how we can actually understand this better. And just a very complex table here, but just to indicate on the top the importance of that. And after you control for that, diabetes is something that independently is a contributor. So again, just to show you that how we need to be thinking about these in the bigger picture of sort of multiple predictors or contributors to overall cognitive status. So moving on quickly to screening tools. So there's a number of them, and they've been mentioned already. These are We're not going to have anybody take these today, unless you want to. You can go across the way. But this is an example of one test that a lot of people are using that I have serious concerns about, and we're actually testing it out. But here's one, the MoCA. CAMP-Key is a computerized test. The CogState is another computerized test. And what we're doing, or what we did first, I'll tell you, is that we have a paper that's just coming out in AIDS, probably in a couple of weeks, a review of the literature of all these tools. And what we did was, these things take time, these search, as Sergio knows, these systematic reviews. So we identified 51 studies that met our inclusion criteria. And the bottom line here with this is that these tools that we have are good for identifying dementia. They're not good for milder conditions. And there's really significant issues with methodological problems with a lot of studies. They're small, don't use a comprehensive battery. Their samples are different and so on. So there were some tests that were identified to have some reasonable sensitivity. But here's a figure that shows just a range of how these tests are performing. And on the very left, this is where our data and the data from California suggests that when you're evaluating these tests, the size of the battery actually matters. So size matters here. So if you have a larger battery, you have a better, it says something about the degree of your findings. And so that's another issue that needs to be addressed. And we got funding from CIHRRC to actually evaluate all of these tests. And so based on that review, we decided that let's address all those methodological issues. Let's get a large group of people, use the gold standard, do good diagnostics, and give the same tools to all these people and see how they perform. So we hope this study will actually, for once and all, solve or address the sort of the issues in the about which of these tests to use, and I'll tell you in a minute about what's the next step. But this looks like a very complex table, but basically what it is the criterion, the clinical diagnosis is me. So this is we do the testing, and I make a diagnosis independent of these screening tools. And then here's how the screening tools on the top, the MoCA, the CAMP-Key, the CogState, the dementia scale, and the adjusted one, and how they performed. And you'll see that the normals, you'll see that relative to the gold standard, or the criterion, how there's lots of variability. And these are just the first 20 people that we've seen. Here's the next set. So there's lots of difference happening. So there's times when I would say they're impaired and the test would say they're normal, and vice versa. And when you actually look at measures of sensitivity, specificity, and the kind of the markers for how tests are performing, you'll see, and the sensitivity is what we want here. You'll see that it's a flip of a coin, except for the bottom where you can actually make demographic corrections and improve things. So that's one thing that's probably helpful. But all these tests alone, so what they're suggesting is that if you use them, they're not good indicators of hand. And we're going to get a little bit fancier and look at, how they pick up ANI and MND. But basically, the bottom line here so far is that they're not, and this is only just preliminary, very preliminary data, suggests that they're not going to do the job that we want. So the next step, actually, in San Diego, they're developing a tool that's on a tablet that we're going to be testing out in our lab. And basically, it's a tool that is designed with all of this thinking in mind. And it's a tool that clinicians will be able to use in their offices. We hope to have it online on a web portal so people can actually take these and then go to see their doctor and do all kinds of, so to help to screen and monitor these things. So we're looking at a lot of different approaches to think about how to do this well. The last piece of my talk is just to highlight this issue of HIV and accelerated aging. And in the literature, again, what we're seeing is that, and what we know is using neuropsychological tests and in particular brain imaging, brains of people who are living with HIV can often look like they're older than compared to, they're older in the sense of compared to people who don't have HIV who are matched in terms of their medical status. And so this suggests that the cognitive impairments that occur in HIV, there's this real parallel between what you see in normal aging. And that that is the real crux of why it's so difficult in terms of screening. This is things that happen with age, but they're accelerated. They're things that happen earlier than normal. And so just to show you that, or not to take my word for it, if you give a processing speed as we get older, we don't run as fast as we did when we were 20. We certainly don't think as fast as we did when we were 20. Too bad we didn't. And you can see that there's a very strong line of how fast we think. It goes down considerably with age. That's not a good thing. And your working memory, so your ability to multitask, has the same sort of pattern. These are the two areas that are the primary areas of how HIV affects the brain. And so you can imagine how complicated it gets when we're now studying this in the context of aging. So the last couple slides are really about what we're now trying to do about it. So here's a study out of the Mayo Clinic a couple of years ago by a really well-known neuropsychologist, Glenn Smith. Did this in aging, and it's an intervention brain fitness tool that's available on a computer. All of these figures, basically what they show is that the people who it's an RCT, the people who got this intervention for 8 weeks got better. They improved their speed, improved their working memory, and their symptoms went down. And a very significant proportion of people. So just look at the second line, processing speed, 80% or almost 80% of those people who are in the experimental group improved versus 32%. This led me to think about, well, if HIV looks a lot like aging, and this intervention helps in aging, what could we do to bring it over into the HIV world? So we did a case study a while ago and showed that this actually really worked. And now this is the program. I don't have any stock in the company. It's Posit Science in San Francisco, so I should just mention that. But it's something that, and there's lots of these programs on the market now, big venture capital companies developing these tools. And what I should say about it is that we now have a study underway. We have about 25 people enrolled, and it looks very promising. But we're doing this pilot study, getting some data that will go to CIHR to actually do a proper RCT. I think it offers a lot of opportunity. If you think of exercise, as all of you are rehabilitation folks, exercise helps. Exercising the brain, should that help? Well, I think so, and I think it does, and this offers, I think, a lot of promise. The other opportunity we're doing is thinking about, in addition to sort of active exercise or physiological exercise for the brain, what about treatments for depression, treatments that have been available? And mindfulness-based cognitive behavioral therapy is something that we're starting actually next week. Drs. Evan Collin and Pat Rockman are going to be, sorry, I have a typo there on her name, it's Rockman. There's some evidence this works in depression, and there's some evidence to suggest that it actually helps to improve attentional processing in the brain. So again, if it works in depression, works in attention, these are the things that we see a lot in HIV, maybe it'll work in people living with HIV who have hand. So this is another opportunity, and this is a group therapy for 8 weeks, and we're testing people before and after to see if those interventions work. As Simon mentioned, this is a group that we've been involved in, really helping to set some standards around what are the approaches in terms of assessment, diagnosis, and treatment. It's included in your materials. I think it's a well-written article of international experts. Maggie Atkinson has a very personal story about living with HIV and experiencing cognitive problems and how she's thought about them, how she's thought through her own sort of how to think about how to address them. And I encourage you to look at it. It's in the Positive Side, Winter 2010. Thank you.